the eighth webinar of the Spanish Academy of Regenerative Medicine. We have a great opportunity because we have a master of regenerative medicine like Dr. Philippe Hernigou from Paris. He was the discoverer of the stem cells in the bone marrow aspirate concentrate in 1989, a long time ago. But
Sí, el fuerte, ellos tienen varios, el más fuerte.
please, the microphone, please. I'm going to silence. Okay. Everybody with the micro silence, and then we can discuss. But for me, the most important question about Dr. Philippe Hernigou is about the collect of the data. Nowadays, everybody's talking about that, but he was a pioneer because he has more than 30 years of register, world register, with many, many data. And for me, it's the most interesting thing about him. You know, we are going to discuss an amazing conference of Dr. Philippe Hernigou, and then we are going to share with him different questions, okay? But America is the country of the opportunity, and I encourage you, when you are passionate, go forward about your passion. That picture is very recently, it's in Denver, 1 week ago. It was the last day of the course, and I was alone in this restaurant, and suddenly I saw the Professor Hernigou having breakfast alone. And then suddenly, you know, everybody knows me. I'm very passionate. I go with him. Isn't it, Philippe? And we share an amazing breakfast in America during 1 hour. He was talking with me about the in issues about the discovery of the BMAC and in pseudarthrosis, and then many college send many patients, and then in fractures, in osteonecrosis, and now in osteoarthritis. It was for me the most interesting thing in my visit in Denver. Okay, he's going to talk about the history of cell therapy. My 40 years experience is really amazing. I think in the world, a few person can talk about this amazing issue, and I think we are going to learn a lot because we are in a chain of paradigms. We come to the prosthesis, arthroplasty in the hip, in the knee, but we are changing our knowledge and mind about the biological paradigm. And Dr. Hernigou is going to explain us. He's more than 40 years working in that field, and this photo it was in IOF. It's an amazing course. I recommend you. And now, for me, I only want to say thank you very much because he has many publications. You can read in PubMed about non-union osteonecrosis and arthrosis. And I think it's time me to shut up, but only to say you are all the webinars in the Academy in the YouTube channel of the Academy. You can see. Even this is going to be recorded. And finally, I would like you to invite people who want to do the new edition of the course, and invite you on February 2027, the 6th edition of the international course OrthoBioMCK, who Philippe Hernigou is invited, and probably he is going to come in. Okay, thank you very much. I stop to talk, and now, Philippe, you can share your presentation, please.
Okay.
Okay.
Okay. And now, I see your you need to. I see your presentation, but
yes. Now I think you can do it.
Okay, I can go.
I think.
But I'm not sure. Okay, but do you see my presentation?
No, not yet. Sorry. Okay, sorry. Right now, please share
Okay.
screen?
Yes, because, okay, now it should be good. So, do you see my presentation now?
Yes, perfect.
Okay, just 1 second.
Yes.
Okay, and now it's correct?
Yes, but I think it's not the first
No,
slide. I think so.
it's not the first one.
Yes.
I have to just go back. Okay, this is the first one.
Exactly.
Thank you.
Okay, let's go, my friend. Thank you very much.
So thank you for your time. I will just try to explain all the possibility of bone marrow concentrate and also cell therapy in orthopedic surgery and probably more. So I have a long experience, as you can see, because I started my research on that in 1985. So it's more than 40 years ago. Of course, as you know, the history of cell therapy is between myth and reality. And if you look about what we want to do, it's very simple. We want to transform a syringe in bone. And maybe we could succeed in some years, but at this moment, we are probably not able to do exactly that. If you check about the history, the first regenerative medicine was described in the Old Testament. As you know, God fashioned a woman from the rib of Adam. So this was probably the first regenerative medicine. And in reality, we know that we can do more because we were the same, because we have the experience of clone animals in reality. Now, if you look about in the Old Testament, sorry, just I have one problem. Just I have done a mistake. I cannot see my presentation. Okay, if you see, it's okay for you?
Yes, it's okay.
Okay, so if you come back about the creation of Eve from Adam process, we know now that from a scientific point of view, it is possible. We don't know if it arrived, but from a scientific point of view, it's possible. If you take two stem cells from Adam, but these stem cells need two nucleus. But we know that this exists because in the reality, in your body, you have many polynuclear cells, and normal in the blood, for example, of abnormal sometimes. So if you just think about Adam stem cells with two nucleus, you can get a new cells with XX chromosomes. So in the reality, from a scientific point of view, this is possible. Now, if you look in time, the first photograph was done in 1770 by Hunter, but he do the transplantation on a cock and on his comb, and he obtained solid bone mass with the first autologous autograft transplantation. The first bone allograft was done by McEwen, and the first vascularized graft was done with a cross-legged human and cross-legged dog in 1850 by Fels in 1878. So all the possibilities probably now have been done in reality. Now, if you look about bone transplantation and cell transplantation, about the mesenchymal stem cells, the idea was described very early in 1867 by Kokenheim in Germany, and in 1868 by Goujon in France, he was a physiologist. And these two people were thinking that probably there were special cells able to transform and do other many cells. But the first reality appeared in hematology with Till and McCulloch, who transplanted hematologic stem cells to treat leukemia. In 1970, the evidence of stroma stem cells was given by Friedenstein in Russia, and he was able to cultivate colony-forming unit fibroblastic that remain the best way to appreciate the number of cells you transplant. At this period, I had my research project in 1986, treating the first non-union in 1987, and the first osteonecrosis in 1988. In 1991, Kaplan changed the name of CFUF to mesenchymal stem cells. And at this moment, this name is probably the name that is currently used, but it represents the same thing as the discovery of Friedenstein in 1970. There were several preclinical studies, and I reported one important thing in the sickle cell disease in 1997, and also there were transplanted MSC in children by Horowitz. And keep in mind that Yamanaka, who is an orthopedic surgeon from Japan, gets
Hay
the
un francés que es un
2012.
monstruo de pituillo.
Sorry.
Yes,
Silent.
I continue.
Yes, yes. Come on.
So what are my best applications for cell therapy at this moment? Probably one of the best, in my experience, is osteonecrosis. Because in this treatment, in this pathology, we had not many solutions. And I have a long experience with cell therapy in different osteonecrosis. This is, for example, corticosteroid osteonecrosis. We have reported a 30-year follow-up with a randomized study of many patients. It was just stem cell therapy versus core decompression. And we followed the patient during 30 years of follow-up. And we remarked that first that the bone marrow implantation after concentration and just injected in the channel decreased the need for primary total hip replacement. And also for the patient who have received, of course, the bone marrow transplantation in the osteonecrosis, this decreased the need for revision and revision of total hip replacement when there was a failure of the treatment. So it was a good indication of the success of this therapy in osteonecrosis. And I reported that also it works in sickle cell disease and in other causes of osteonecrosis. The second indication at the beginning was the treatment of non-union. And I reported in the Journal of Bone and Joint Surgery that we could, just with a percutaneous injection of autologous bone cells, bone marrow concentrate, treat a non-union. And this was the first report in the world where we could demonstrate that probably the total number of cells you inject has an importance on the results. It was relatively easy to demonstrate as we could measure the volume of the callus in this patient and do a correlation with the number of cells that were injected. We also have done in some patients with difficult cases. This is, for example, a non-union and diabetic patients with abnormality in the vascularization. and we treat due to a gunshot, and we were able just to treat with external fixation, bone marrow concentrate injection to obtain healing. We have used also in revision arthroplasty. As you know, in difficult revision arthroplasty, you need some time to do allografts, and we were thinking that using allograft may be sometimes not enough, and we injected in the femoral head allograft bone marrow concentrate to increase the healing of the allograft in hip arthroplasty revision, and you can see here. And this is very easy to do. You do the bone marrow aspiration, the concentration, and in the operating room, you inject the femoral head that you will use after for the hip arthroplasty revision. We have treated also the rotator cuff repair, not only tears, but arthroscopic repair with mesenchymal stem cells to improve healing and of the patients. And we have done a case control study that demonstrated that the benefit of this treatment. We use also cell therapy for knee osteoarthritis since a long time. As you know, there is discussion about injection in the joint of injection of the subchondral bone. Anyway, because I have experience of the benefit of bone injection, my choice was to inject the cells in the bone, in the tibial plateau and in the condyle to treat osteoarthritis. And you can remark that the decrease of stem cells in the knee is much more important than in the iliac wing for these patients. And the rationale to inject in the bone is the decrease of cellularity with MSC in the subchondral bone in patients with osteoarthritis, whether it is in the knee, in the hip, or in the shoulder. So you can treat all this osteoarthritis with subchondral bone injection with autologous bone marrow concentrate. And one other example, of course, in young patients with severe deformation, I do an association of high tibial osteotomy and cell therapy. This is, you will see an example. I use the technique of opening wedge tibial osteotomy as I have described in 1987 in the American Journal of Bone and Joint Surgery. So an opening wedge technique with autograft. And so this is the results at the same time. Sorry, at the same time, the osteotomy and the cell injection in the subchondral bone. And you can see the results in many situations. This patient will receive a total knee arthroplasty, and you can see the result just with high tibial osteotomy associated with bone cell therapy. I have proposed also to do in a patient with spine and disc disease to do an approach for vertebral end plate with a subchondral injection. It's a transpedicular approach. We can inject in the subchondral plate and the end plate of the vertebra to treat discopathy. The technique is relatively simple. You need fluoroscopy, and of course, you need to target correctly the pedicle, but with fluoroscopy, it's not very difficult. And after, you can inject the bone marrow concentrate to treat disc pathology. I have done also some pediatric patients. This is an example of treatment of leg discrepancy with the calostasis and bone marrow MSC injected in the calostasis. This increase the speed of repair, and you can do the calostasis, and just around 2 months perform the injection of bone marrow concentrate in the calostasis to increase the repair and to obtain the strong repair at only 6 months. So just I will speak now about what is the safety of the stem cells. This is one of the most important problem I have to resolve, because when you do this kind of surgery, the national regulation of your country, of course, ask you to prove that there is not only efficiency, but also some security about the patients. And I reported in 2013 in the American Journal of Bone and Joint Surgery that when we were treating this patient with autologous bone marrow concentrate, there was no increase of cancer risk in these patients. We check about a large number of patients, around 2,000 patients, and with a long follow-up, it was more than average 12 years of follow-up, from 5 to 22 years. We have always this patient about follow-up, and we now have 20 years of follow-up for this patient, and the results have not changed. There was no MRI or radiographic evidence of tumorigenesis at the treatment site. We selected patients with osteonecrosis, hip osteonecrosis most of the time, but also shoulder osteonecrosis, and so on. This was easy for the follow-up, because this patient had MRI. So because they have MRI for follow-up, we were able to be certain that there was no recurrence on the site of injection, on the site of osteonecrosis. And you can look about the number of MRI, 2,000 MRI, and at 2 years, and a total of 7,000 MRI and 52,000 radiographs that were examined to be certain that these patients have no increased risk of cancer. We, of course, because these patients were followed during a long time, there was some cancer, and we find a total of occurrence of cancer of 53 during the follow-up period, but this was less than the calculated incidence in the general population in France. So normally we should have observed around 100 cancer according to the follow-up of the age distribution, but we observed only 50 cancer. So the conclusion that was there was no risk of cancer in this population. And you can see the patients with occurrence on cancer and the dose that was received, and there was no correlation because between MSC dose and cancer frequency. So the conclusion was that there was no risk of increased cancer with autologous bone marrow concentrate treatment in these patients, and we will see later that we can also do in some patients with cancer. This population, of course, has no cancer at the start of the study. What will be the future and the progress? Of course, the situation is changing every 5 years, I will say, or every 10 years. Now we are able to do expanded autologous stem cell and also expanded allogenic cells. It's not allowed in most of the time, but we get the authorization and from the regulation of France to do some patients in specific situations. So first, we have to remain that the number of cells we can obtain by concentrate bone marrow is relatively low. You get, depending of the patient, depending of the way you do the aspiration, a number of cells that are around 100,000 in good times, sometimes less. But anyway, there is probably a relation with the number of MSC and the results. So the idea was to do a culture in vitro, and we were able to obtain in the lab several millions of MSC, around 200 million of MSC in some patients. So the idea was to provide, so for the patient with very severe non-unions, the expanded MSC with some biomaterial in the non-union, and we perform that with bone tissue engineering. So one bone marrow aspiration, 10 cc are enough in this situation to expand in the lab by amplification, differentiation, and during usually it's around 21 days. It can be less or a little more, depending on the number of cells you obtain and not only the number of the quality, but also the quality of cells you get. Anyway, we have reported the feasibility and the results in a study, and you can see that osteoprogenitor cells stick on ceramics, and you can also see that they provide some new matrix in the lab, but also in the patient. This is a patient with a severe non-union, a large defect, so just concentrate bone marrow was evaluated as non-sufficient, and this patient gets the authorization to have expanded autologous stem cells, and you can see the results after 1 year. You can also probably in the future do expansion MSC on some on arthroplasty, because this can be done for difficult arthroplasty. You can put MSC on the surface of the joint. What are the way of administration? Most of the time, the way of administration in my practice is, of course, bone intraosseous injection. But there are other ways of administration that are possible. Of course, there is joint injection, but also you can imagine other way, because it can be done directly intra-arterial. For example, in China, in some patients with osteonecrosis, they are not injected in the bone, but they are injected in circumflex artery to at the same time to expect some neovascularization and injection of the cells in the osteonecrosis. And you can also, for some patients, we have done intravenous injection because the patient has multifocal osteonecrosis, and we needed a lot of cells in patients without normal MSC. This was done different parts of the world, and we have done that with patients with sickle cell disease who were not. It was impossible to get enough autologous stem cells, and we have done a preparation of allogenic bone marrow derived cells and we reported that in the American Journal of Bone and Joint Surgery in 1997, and for the treatment of patients with multifocal osteonecrosis in sickle cell disease. And this patient has a direct effect on osteonecrosis. You can see this is one of the patient has multifocal osteonecrosis, but this is one example with a shoulder osteonecrosis. and he received a high level of dose intravenously. And you can see the repair in this patient that was a child, a moment of injection, and quasi total repair of the shoulder. I will continue and finish with some other indication and other risk. One of the things that is discussed actually is the possibility to use stem cell therapy in patients with malignancy. We know that we have no problem when we treat patients without cancer. We are not certain that we can use treatment for indication in malignancy. But anyway, we get the authorization because I have worked a lot with the Department of Hematology to do this treatment for osteonecrosis in patients with hematologic or solid cancer. You can see a large number, 253 patients. Some cases have been reported, although no, I will give you an indication. This is, for example, the risk of osteonecrosis in hematologic patients treated with for leukemia because they receive chemotherapy and also they receive irradiation. They have a high risk of hypostenecrosis. And we discussed about which way was the best to use allogenic stem cells or to treat this patient with autologous stem cells, because the risk is when you do aspiration in the iliac crest, if there is recurrence, of course, you can, there is a risk that you aspirate some cancer cells. But anyway, the hematologic department gave the authorization because they were thinking that it was better to use autologous cells. And we have treated this patient and we found that there was no MRI evidence of tumorigenesis in these patients. And when they had no recurrence, and this was the case of most of the patients. And we have also, of course, some patients with recurrence of leukemia, but this was not related to the bone marrow aspiration. Just a way to do bone marrow aspiration in pediatric patients. Of course, these patients, when they are children, have the cartilage growth of the iliac crest, and it's better to perform a transpedicular approach to avoid to cross the gross cartilage of the iliac crest. You can see that there is a decrease of autologous stem cells in this patient between the time of before the chemotherapy and after chemotherapy. But anyway, they have enough cells in most of the patients to treat them. So just the way, and so in this patient, even in this patient with hematologic cancer, total lip arthroplasty, when performed, has some complication. We had infection, and we had also other wound healing problem. So when we treat this patient with bone marrow concentrate, you avoid the risk of infection in this patient at the time they have treatment for their leukemia. Thank you for your attention. I stop here because if you want to keep some time for the discussion, we need to move.
Okay. Thank you very much, Dr. Hernigou. Amazing conference. And we have learned a lot about your big experience. And now is the time to question. I would like if any assistant has a question, we have a chat. You can write the question and I will transmit to Dr. Philippe Hernigou. Okay? I would like you to encourage to do question and to debate. I have many questions, you know. It is really amazing the big amount of indication and publication you have. I think it's all of one life of investigation and hard work. Really amazing. My first question is about your your influence in French in your college. You told me about you start alone by yourself, and many college start to send you many patients of about cellular arthrosis, non-union, and then your indication and your experience grow a lot. But tell me about the French society and the indication and the grade of average of BMAC in French is a very it's a popular treatment. It's no many doctor who practice every day. What did you discuss in the society in French society?
The problem is that you need an authorization from the Ministry of Health to perform this treatment. If even for bone marrow concentrate, it's considered that homologous treatment and autologous treatment, but the regulation does not want that anybody do that. So you need to ask an authorization to perform, and you need to demonstrate that you will perform enough cases in one indication or several indications.
That's the reason that there is no a big indication in France about orthopedic surgeon, I suppose, no?
Yes, because even for PRP, for example, it's they need an authorization, but it's more simple to get the authorization.
Yes. Okay.
But
Okay.
for bone marrow concentrate, we are probably, I will say 10 center, but only university center
All
have
right.
get the authorization. Because
Okay.
you need to prove that you can work with a cell therapy unit to count the number of cells you transplant.
Okay. Okay.
You need to keep an alicot for your bone marrow aspiration, and you need to prove that you have get enough cells for your treatment by culturing this alicot for the number of colony-forming unit fibroblastic. So
Oh,
it's very controlled.
it's a problem, yeah, because not so many people can demonstrate the amount of cells, no? Talking about the PRP or microfat, do you use this other orthobiologic? You combine with BMAC or you never use it, PRP or
No,
microfat?
we don't use PRP at the same time because we have a preparation of BMAC. We keep the platelets.
Yeah.
We keep the platelets. So we were thinking that it was not necessary to add PRP because in the bone marrow concentrate, there are two ways to do bone marrow concentrate. There are some preparations that remove the platelets. There are other preparations that do not remove the platelets. In the bone marrow, it's not exactly platelets, it's megakaryocytes, it's just the progenitor cells.
Okay.
But these have some advantages because platelets are sensible to aspirin, for example, but the precursors are not sensible to aspirin. So you can do bone marrow aspiration even in a patient with aspirin treatment. You don't need to stop, and you can also, when you inject, you have both MSC and platelet precursors.
Okay. Um, the Brazilian School of Regenerative Medicine of Fabiolana he used a lot of aspirate, but they never concentrate. What do you think about that school who never concentrate? They demonstrate that the stem cells are in the same average. Do you always concentrate, or you shot?
In children, for example, you have a high number of progenitor cells. In children of 10, 11 years, they have a high number of MSC. So probably it's not necessary to concentrate because the level of MSC is so high that, but you need to have enough bone marrow aspiration. The problem is that when you, even if you don't concentrate, you have a large volume of bone marrow aspiration. You need to get enough aspiration, and you get a big volume of bone marrow, and you don't need to inject so large volume of bone marrow. So this is one of the problems. But anyway, I will say that in children it's possible. In adults, if you will not get many MSC if you don't concentrate because
Blood.
it's really difficult.
Dr. Luis Gallego is from Almería. Hello, Luis. He has a question. Dr. Steve Sampson from USA published a paper about boosting BMC with PRP injection after some weeks with knee arthritis. Again, do you recommend the combination of BMC and PRP, or you don't think it's necessary? Thank you.
I will say it's not necessary to combine, but anyway, but the most important is to inject the MSC in the bone, and you combine the PRP in the joint.
In the joint, okay.
Because there is a rationale to inject BMAC, bone marrow concentrate, in the bone, because when you inject, the cells stick to the bone, so they remain and they stick to the subchondral bone, because this is one of their property, the same as they stick on the plastic in the lab. But PRP has not this property. So if you inject PRP in bone, they will go and immediately in the systemic way, and they will not remain on site. Because the effect is very short, the effect of PRP is a short effect of 3 or 4 days, and for growth factors. So I would say that it's more reasonable to inject PRP in the joint than in the bone, and the reverse is true. It's more reasonable to inject bone marrow concentrate in bone rather than in the joint.
Okay. Doctora Claudia, he has a question about your experience in osteonecrosis. If you recommend BMAC over PRP, and why? I think
I will say that if you inject PRP in osteonecrosis, there is just an effect of growth factor. But as soon as there are no cells in osteonecrosis, by definition, if you put growth factors on no cells, the results will be 0 or very limited. So the rationale is to inject cells in osteonecrosis because the repair will be more efficient.
And by the way, do you have to repeat this process? How long is the effect in the patient? How many times have you done a treatment in a patient, for example?
Normally, one shot is enough.
Only one?
One shot enough. In some patients, in osteonecrosis, I have repeat injection, but when I repeat injection is usually 1 year. 1 year later, I wait 1 year. If the patient has, for example, no collapse, but on MRI still an active osteonecrosis and some pain that persist, I will go again and do a second shot in the osteonecrosis. I have probably 100 patients or more with this kind of treatment, repeat injection.
Okay, okay. Okay, let's go now to the spine. There are two questions. We combine the same question because they are asking about the indication in pathology of the spine. Have you used BMC in disc? Have you seen BMC in the treatment of the scoliosis or in spinal fusions to enhance bone healing? What are your indications in spine?
The spine, I've done first some injection in the disc,
Disc?
but I was not satisfied because with the injection in the disc, you can inject only a small amount. And it's very small amount, and at this period we were doing concentration. And so if you inject perhaps where we say 2 or 3 cc, and after normally if the annulus is correct, you cannot inject more. And if you inject more, that means that the annulus is as a tired, and the tear and the bone marrow will go away. Anyway, when we were injecting in a patient with modic 1 or modic 2 end plate, we were injected in end plate in the vertebra, just above the disc and below the disc, and we were able to inject in each vertebra around 5 or 10 cc. That means the patient was receiving between 10 and 20 cc of bone marrow concentrate with more cells, and the results were better about pain for the patient. We had done some injection for fusion. We have published a comparison with BMP and the fusion and bone marrow concentrate in the injection in the fusion. It was done with autograft, one autograft supercharged with BMP and one autograft supercharged with bone marrow concentrate. And the results were, I would say, the same about pain and fusion, but we have less complication with BMAC because we had some complications with BMP about ossification.
Okay, okay. For me, has been very interesting. You have demonstrated that there is no evidence of tumorigenesis. It's very important because some doctor who doesn't know about these techniques is always talking about watch with the stem cell about the cancer, no? And you have demonstrated there is no evidence. For me, it's very, very interesting. I would like you to talk about your technique, Dr. Hernigou, because here there is doctors who are starting to do this technique. I would like you, if you don't mind, to talk about your procedure, your technique, the type of needles, how many cc, the cell niche you take, posterior or anterior crest, how many cc you put subchondral bone. Please talk about your techniques.
Yes, it is the idea of the process is very simple, but the technique to get enough bone marrow cells is not so simple.
Okay. That's very important. Not
yes,
everybody
very
we have to practice.
Yes, to describe correctly the bone marrow aspiration technique, probably we need half an hour. But anyway, the most important point are there is no difference between anterior iliac crest and posterior iliac crest. The number of cells is relatively similar, but if you start, the posterior iliac crest is easier because it's thicker and it's easier to do bone marrow aspiration from the posterior iliac crest when you start. Another point you have to take in consideration is your patient is awake. It's easier to have a patient just it's easier to perform a posterior iliac rest because the patient does not see you. If you are doing in a patient awake with local anesthesia and anterior iliac rest aspiration, it's more difficult because the patient is looking at you,
Yeah.
and so you need to have a bigger experience to do that. But the most important is to take in consideration the size of the syringe. The size of the syringe is important. The most important probably aspect is to use a 10 cc syringe. The smaller is the syringe, the better it is, because the force aspiration is better. And there have been many experiences performed 30 years ago, and you get more MSC with a 10 cc syringe than with a 20, 30, or 50 syringe.
Okay.
But also you need to fill only half of the syringe. Though when only MSC are in the first half of the aspiration, and the better syringe should be an insulin syringe, just 1 milliliter syringe. But of course, it will take a lot of time to aspirate. So
a mini syringe.
Yes, it's a compromise between the size of the syringe and the time of the process. But anyway, the best at this moment is probably to use a 10 cc syringe.
What kind of needle you use? The Jamshidi normal or with different holes?
I started with at the beginning, I started with the Jamshidi, the old one, with just a distal hole. After I've used the new Jamshidi with yes. I will say that there are differences. It's better to have several holes from a technical aspect because sometimes the distal hole may be just I will say will not work because there is some bone inside, and you cannot aspirate.
Collapse.
Yes. But at the end, whatever the Jamshidi needle, the number of cells is more related to the size of the syringe than to the Jamshidi needle.
Okay. And then you use any anticoagulant, heparin, ACD, citrate, or ice, because Fabiolana don't use anticoagulate. He put the stem cell in ice and then shot directly. What kind of anticoagulant you use?
The best, of course, is to when you treat a large volume of bone marrow, the best is to use ACD and not heparin. You can use heparin, but if you use heparin, you have to be very careful about the dose of heparin, and don't use pure heparin.
Okay.
Use dilution of heparin. The risk you have to keep in mind that when you rinse your syringe, there is some heparin that stick to the plastic. And as soon as you do many aspiration, many syringe, you get some heparin in your bone marrow. And when you will inject the bone marrow concentrate, you will inject heparin also.
Yeah.
And you may have some systemic effect in this situation.
Okay. And then how many cc do you put into chondral bomb? It depends about the pathology, but normally 4, 5 cc.
Normally I try to inject 10 cc.
10 cc. This is high volume.
Yeah, 10 cc. I will say that it depends, but the problem is not the volume, but the number of cells you get by the concentration. If for example, if you are certain to have enough cells in 5 cc, we say it's okay. The problem of when you inject only 5 cc, you have in your syringe 5 cc, but you have a dead volume also. So dead volume is the bone marrow that will remain in the syringe and in the trocar. When we fill a syringe of 5 cc, you cannot inject more than 4 or 3 cc. because one part remains stick to the syringe and one part remain also in the trocar of injection.
Yes.
So this is one of the problems of the small volume injection. You cannot inject the totality. If you inject 10 cc, you will lose probably only 1 or 2 cc, but you inject really 8 cc.
Okay.
So
Okay.
it's a compromise of the number of cells and the volume you inject. Keep in mind that when you inject small volume, due to the bone marrow that remains stick to the syringe and to the needle, you don't inject the totality.
I suppose you do all those procedures in the old room with the patient with sedation, so I suppose, in
Yes.
regional anesthesia. Um, what do you think about the team that they are using this technique in ambulatory, in the clinic with local anesthesia? Do you agree or do you think it's not a good idea?
I will say it's possible, but it's possible if you have a large experience. Because if you start by using without general anesthesia, it would be more difficult. I don't say it's impossible, but we say that you have to probably go and look about somebody doing that with general anesthesiology, because it's clearly more simple to start on a patient with a general anesthesiology.
I am very friendly of Fabiolana group, and he demonstrate. Uh, I have seen different videos with local anesthesia, posterior iliac crest, with ultrasound or blind anatomic reference. They put local anesthesia. They wait 5 minutes, and they distract the 10, 20 cc of blood, and it's well tolerated. But the question I do, what's happened with that kind of patient that suddenly it's painful, and what are you doing? No? For me, I agree with you. I always doing in the old room. I think it's more security about the patient. I think so. No.
Yes, I don't think they have a lot of pain. Bone marrow aspiration is just painful during I would say 1 hour. After 1 hour or 2 hours, the patient has no more pain. So I would say that if they have some practice, the problem is not pain.
Okay. Um, Now let's talk. We 9 o'clock. 2 more minutes, please. What do you think? The end of your conference, I was astonished because you have talking about the intra-arterial and intravenous VMAC in China. Do you think really has a application in Europe? And what
No.
about the complication? Uh,
No, no. I think, but anyway, we need to think about the use of BMAC was used by heart surgeon and by vascular surgeon. So they are doing in vascular disease. They are injecting bone marrow concentrate for vascular disease and also for heart infarctus in heart surgery. So why not?
Okay. The last question, you have talked about the cultivate, the span cells. Um, do you really think that more therapeutics is that the advantage are really about the cost and the preserve the time, 21 days cultivate, and then the second preserves. Sometimes we need to look for the best combination of quickly, safety, cheap, preserve, and good result. No? And then, in your experience, which is your average of cultivate or expand cells? And
No, cultivate is, I would say, is very more experience, very anecdotic because I have
anecdotic. Okay.
anecdotic because I have probably done more than 10,000 patients with bone marrow concentrate, and only, I would say, less than 100 patients with autologous cells with expansion in before.
Okay, okay. The last question, Dr. Hernigou. In which tissues do you think BMAC it has the most effect? Is it bone, is cartilage, is tendon, other tissues?
For me, the most evident effect is in bone. But of course, you can use for, I have used for rotator cuff tears in tendon and injection in the tendon and the footprint of insertion of the tendon. I will say that also this is very helpful for rotator cuff disease because it's very difficult to get healing of the tear. Probably also in joint, for example, for patients with a specific disease in joint like a meniscus tear, meniscus suture, anterior cruciate ligament repair, adjunction of bone marrow concentrate is helpful for this kind of intraarticular injection joint.
Okay. Okay, Dr. Hernigou, I think it's 5:05. And then it's time to say thank you very much for your time, for your amazing experience. Thank you, all the teacher of the Spanish Academy of Regenerative Medicine. I have enjoyed a lot with your experience. You are a master. I know about you, about the paper, but never in person. And we all of the present and this meeting will be recorded and put in the YouTube channel. I assure you that many people will watch later, and thank you very much for your time.
Thank you for your time also. And now have a good dinner in Spain.
Yes, yes. See you in Spain and have a look. Good luck in the World Cup. France and Spain probably in the final. We will.
Maybe the two best teams.
Yes, I think so. I think so. Thank you very much. Bye bye, everybody.
Bye.
Thanks for coming. See you soon.
See you soon.
Bye bye. Luis, bonito bigote. Bye bye, amigos.